All right. Hey, look, we're on the air. This is my first inaugural podcast with Christopher Hinnerichs. And so Christopher Hinnerichs is a good friend of mine. I've known him for how many years now? Have I known you?
Dude, it's been since probably 20 plus years now.
Yeah.
Over.
It's been a minute. It's been a minute. And so part of like what I really just respect about you, and you know this, is I just love the fact that you went so deep into higher education, and you've done fascinating stuff with it. And I think it's just time for people to hear about it. So maybe just tell us like maybe a little bit more about what you do, or whatever you can say. Like, what would you say like your biggest job is currently? Because you've had many you've held worn many hats.
Yeah. So I think, my primary like start in public health was at state health department level. And mostly I was doing that as an internship level while I'm going
Huh.
through grad school. And, there's a lot of great things in that venue too, but the focus is what the state issues are in any joining state that are close that, disease could travel over there. So it's a good experience, but it's very limited in scope. And so I think just in general, as we kind of go through maybe some of the question sets too, is where is some of our gaps that we have out there in public health? And I would say it's that international focus. And I think over the years, I was able to get that through military public health, because you're not just worried, you're also looking at the state you might be in or the country you're in. But I've said this for years. I think the number one vector of disease transmission is the aircraft, because within hours from a regional endemic disease, you could be in another place mingling with a susceptible population quickly,
Huh.
but it just now could turn into a pandemic. And we have to get over the stigma of like, oh, we protect our ground, our state, our country, because it's a global threat. Again, if the aircrafts are going every direction and coming into our big airports like LAX, where you're at, Chicago O'Hare, Atlanta, JFK, massive communication of disease that could start happening within our own area. So anyways, I think that's what helped with mine is from the very start, got that global aspect of it. And from, I think it was my second assignment is I got to work on Ebola treatment facility and screening station in Sierra Leone. One of the, I think, deadliest infectious diseases we've seen within our time, and something, I've only read in textbooks. And then now I'm supporting a factor like that. And then it would jump into, at the time, I was still just trying to finish up my doctorate. And so looking for a dissertation, topic within it. And then it kind of spread to when I got my next assignment in the Pacific. That's when swine flu came up, H1. We didn't know what it was at the time. We knew it was some novel influenza strand. And so again, we saw that in one region. It was in Guam, where we picked it up initially. I mean, it was probably over the globe already at this point, but that's kind of where the research kind of led me into that. But I think everything we're at, and even dealing with old, I would say, legacy diseases that we pretty much eradicated, like polio, that was still endemic in Afghanistan, and we're still vaccinating our troops against it. And we came in contact, and we'd pick it up on some of our lab analysis too. So things that we just don't see in the States, you'll see it on that global level, but
Uh,
also knowing they could be in our back door at any time as well. So that was a great thing, I think, military public health.
uh, my God, and that sounds just. I mean, like every single time you told me a story before, I'm always just like really listening. And it's so fascinating compared to most people's normal lives. I mean, it's just really is a little bit like what you see in the movies, and of course, like it's really doing some major protecting for for public health and for individual national security, all these other things. But let me ask. Here's so speaking of like your dissertation. So I know like you did a doctoral dissertation when you did your PhD, and it was focused on thermography and influenza-like diseases. And so I think you probably got what led you into that line of research? Was it the H1N1, the swine flu, and then that's like the thing that kind of got you thinking about doing that, how to detect the flu?
Yeah. No, that's a good question, because that was my crossroad. I think I was going through the studies, knocking out the didactic stuff. And then I was going back to my university and seeing like, hey, is this a topic of dissertation like worthiness? And I thought there was a big one I was on. It was called JTAPIC, joint trauma analysis and prevention of injury and combat. And
Uh-huh.
basically what that was looking at is vulnerabilities in our protection equipment. So the Kevlar that we wear on our head to protect us from blasts and from potentially small arms weaponry to even our bulletproof vest that we'd wear on there. And we're starting to see, and we're comparing it to fatality injuries. So that was a good epi study to see, okay, what caused morbidity and mortality? And then where was there a materiel failure within it? And so from that, we got a lot of new advancements within our protection environment. One we saw, believe it or not, in Afghanistan and Iraq, there are
Uh,
water areas out there and we would see rollovers. And when you try to get out of tanks and different carrier devices, when you have this heavy vest on, that was some of the things that some people weren't able to get out of those. One, they couldn't move fast enough with those on, or they couldn't release it to get out, or just think if you hit in a water area, you can't swim those on because the vests that the military wears are so much heavier than say the police wear. And so we looked at those fatalities. We did see drownings was one
uh,
of the things. And so we came up to a quick release that's on now the vest that we wear today. And so you can drop the armor if you have to get out there, say if there was a fire, explosion or
uh,
something, you have to move away quickly. Or if you're in water, you would drop it. Another thing we saw is axial hits. So underneath the armpit where, shots would come in because our vest wasn't going up high enough and
uh,
protecting us. And so we saw a correlation with that. So we readapted the vest to have those protection and then even femoral hits. So we have different components you can put on the vest to protect different regions of your body, depending what up armament you want. So
uh,
anyways, I brought that back to my university saying, hey, this is novel. We're going through this. It's, saving lives, doing a lot of things. And it was a quick thing as that's not what we're quite looking for. And so I was going on the tail end of my program too. So I was like, okay, I gotta quickly do something more on this. So my next assignment, luckily I came there. There was a public health service officer that already
uh-huh.
procured these very expensive infrared cameras. He had this
Okay.
concept of what he wanted to do, but the whole thing is we had no population. And going through IRB processes, we'd have to do it through the military and my university. I was running into all these, it just would be a lot of work. And so it never happened. And I was thinking, okay, this is going to vanish. And then I got a call. I was actually inventorying these cameras down at Pearl Harbor and they had emergency alert saying, hey, one of our ships coming into Guam has a high uptick of influenza-like illness aboard, and they want to
Uh,
send a public health team out. And so I was like, hey, is it all right? An Army guy jumps on a naval vessel. I'll be part of the team. I got these cameras where we could screen them, also do oral thermometry as well. And we're pulling blood too. So we actually had serology reports beside it too. And I was like, what's nice about these cameras? I can get a heat signature in less than a second and we can be 10 feet away from them. So if they're infectious, that's going to help us so we don't pick anything up as well. And
wow.
so they're like, yeah, jump on board. And poof, that was my study. And in an emergency situation, you don't go through the IRB process. The ship was a very large carrier and so had, thousands of folks on it. So good population sample size. And, I just quickly called back to the school, told them
Wow.
this is, what I'm doing. And then they approved it. So that's where it began. So it was kind of a luck and being in the right time at the right place. And that's where it kind of spun up from there.
I mean, that's part of like almost all of life is just sometimes you have to be ready for the luck, right? So luck doesn't find itself. Like you make yourself lucky, but you're ready for that a moment in time. It looks
Right.
like.
Exactly.
How cool is that? Well, I think part of I've been through a lot of school, and you've been through a lot of school as well. And so, how do you think like your academic training compares to the realities of field epidemiology? Like once you're out there in the real world.
Yeah. And, that's kind of a hard one too. And I think we touched a little bit on the beginning and it was, I think every public health program and even ones that I've guest lectured in and stuff too in different areas, they focus on that state or that region. I think it goes back to the whole thing is, especially when you're dealing with infectious disease, it's a global issue. We used
Uh,
to, back in the day when we didn't have as much travel abroad on aircrafts. Yes, it's very
mhm,
limited of, where they're going. And now within hours, we used to have borders that would protect us against infectious disease, oceans that would keep us distance away from, these transmitting. But now and apparent infection too, right? You could actually be exposed. You're not feeling it yet. You are shedding the virus, and then you're jumping aboard an aircraft and coming back. And I think another failure in the system is, and it kind of goes back to public health, is what we do at our quarantine stations around the area is basically self-report that you're sick or you're not, and a vigilant flight crew. So just crew, if they see signs and symptoms that you're very ill, maybe bloodshot eyes, you're going to the laboratory very frequently, you might be asking a flight attendant, hey, how close are we there? I'm not feeling so well. Or
Mm,
sometimes aboard an aircraft, you'll hear a page, is there a doctor aboard? Cause it's
yeah,
a very ill passenger that needs help. Those are what gets reported to our quarantine stations. And that's what alerts them.
interesting.
And my whole
Ah,
thing was about it is we need a screening tool. We don't like, that's not enough just to go through and say, no, I'm okay. Are you sick? Or are you not? Yes, it catches some, but I think if you really did the studies on it versus what gets through, you need another way. And even too, when we look at infrared thermography, it is a tool. It's a screening tool that can help us capture those that are ill without going through self-report and vigilant flight crew. Now, does it have its shortfalls? It definitely does. But anyways, going back to that, I think that's what makes public health, what you learn in academia, and how it doesn't stretch out into the global thinking of infectious disease, because it's definitely global. It's not regional based. So that's, I think, the gap.
I didn't realize like how important. So I guess when you're on a flight and you're flying from one region to another, and I mean, it makes perfect sense that these flight attendants and these pilots and flight crew and all those folks, and even like the people who are at the gates, probably have been trained and like are given training on what to look for and who to report because it is such like a global problem. And so I guess that kind of brings me into another question. I mean, you kind of already answered it, which is like the biggest operational and epidemiological challenges in running a geographical dispersed system. Sounds to me that, I mean, what would you say that what would be the biggest challenge in running an because you have run these type of systems, from multiple, Pacific Rim, multiple continents, etc. Like, what is the biggest challenge in running something that dispersed?
That's a good question. And it depends. That's a regional one for sure. And being in the Pacific, where our command looks at is from India up to Mongolia, all the way over to California, and then all the way down to New Zealand, about 49% of the world's surface. And what
Mm,
makes that even harder is it's all in blue,
crazy.
most of it. So a lot of distance in between. So our response time is definitely delayed. So they always say the tyranny of distance. That's what the Pacific region really focuses on because it takes so long. So for instance, if I want to get to Guam from where I'm based here in Hawaii, at minimum 7.5 hours. And we
Mm,
always use the term gray tail. That would be off of a military aircraft where I can just roll down. I know their scheduling and go out. Now, if we have to do commercial, you're based on
mm,
when commercial flights are going out and I have to go through custom. Well, we go through customs both ways, but it's faster and expedited through military air. Now, look, if we wanted to go to Japan, about 9 hours to get any response that's from here out to that area. LA, where you're at, I'm looking at like 6 hours. Or if I have to get up to Seattle where another bases are at, then that would
mm.
be about 6 hours. So response time, and it's costly, right? To move out here, I can't take a train. I can't jump in my car, get a bus. We don't have that. It's all in blue, right? So we're paying top dollar to get movement. So that's what I think really makes it a challenge. And another thing too is just this year, this fiscal year is drastically reduced in what our operating budget is from last year. And we're told in 27 it's going to look better. But again, like a place that's, I think most of our operational budget is just getting to point A to point
Wow,
B.
that makes sense.
And so other places don't have it. Like look at Europe, for instance, there's very cheap flights because you're not going that far. There's trains all
Mm,
over. You can actually get in vehicles and drive. You don't have that same restrictions. Southern Command, same thing, not as much that whole blue in between, and it's a lot more congested area. And then where we live in the United States too, a lot easier to get around there and cheaper. But yeah, when you're looking at the Pacific And look, where historically most of our epidemics are coming from and pandemics, Southeast Asia, historically. So that's in our area of responsibility. But to get to those places, timely and costly.
Wow.
So that's our
I,
biggest challenge.
I never thought about it like that. That is, I mean, that makes perfect sense. 49% of the Earth's surface on this side, and I know, I think, isn't there a point, there's a point or an island, or there's like a, where you can't get into any, like, there's no humans within 2,000 miles, and it's within the Pacific. And I can't remember what that point's name is called. It's like point something, and it'll come back to me. I find that
Yeah,
just so,
yeah.
it's
But
like
with
point zero, or something like that. And it's terrifying and fascinating at the same time.
Yeah. And that's it. Even like mine, you just don't see how vast the Pacific is. And I think when I really noticed it is again when I was doing my study for the outbreak investigation where
Mm.
I met the carrier in Guam and I was part of the crew from Guam to San Diego and just out in that blue. And when we did have some downtime to go up on that flight deck and just look out as far as your eyes can see, it is just blue. And then when you start to come into weather patterns, even this large carrier is moving around there and you see how violent the storms that go through there. And, then you feel so small because you're like, wow, there's a
That makes
big
sense.
distance. Because when you fly it, it's still long flights, right? But it's not as long as if you're taking it by a ship. So, that's when the reality of like that distance period. And that's even too, that could be some of your logistics support, right? So if we have a big public health crisis and we need logistics support. So we have mobile labs within our area. So we can do for if it's more like
Mm.
chemical related, then we can look at gas chromatography, mass spectrometry. If we want to do more biologic related, we think it's some infectious agent, then we have utilization to mobile PCR and next generational like gen sequencing. We can bring that out. And these are in kits too. Some of them are containers that would be on back of semis and then loaded into ships. But just saying, you can send a team, again, kind of what we looked at. So let's look at Japan for example. We could get there in 9 hours on a flight. The teammates, the scientists that will be working out there. But then our logistic, we have a couple things we can carry, maybe a duffel bag, maybe a couple briefcases, some Pelican cases of equipment. But if we need more than that in our lab, that's coming on logistics, which is usually by sea because it's much cheaper than flying it in. But then that goes back to that whole time and cost. So if I want to get
Yeah.
that all in there, a lot of blue to cover before all of our support, is there.
Several days minimum, I'm sure, right?
Yeah.
And the pandemic could be raging at that time, because
Yeah,
every pandemic goes at an exponential level in terms of
for sure.
infectious. Wow. Well, I think, like, probably, going back to U.S. side, I think, like, covering, for the whole Pacific Rim. Like, what do you think? Like, because we do live in, we're United States citizens, and we live in the U.S. and what do you think, like, the biggest vulnerability of the U.S. public health system is, that people just don't really see?
Yeah, that one, I think if you really go to the core of it, it's the lack of a integrated biosurveillance network. And so when I
Mm.
say that, we got a lot of heavy hitters that are out there. We got the World Health Organization, National Institute of Health, Centers for Disease Control, military Prev Med, and I mean is phenomenal. Like what we can do there. We got state, health departments,
Mhm.
and they're all. And so we the best I've seen it is here in the Pacific, where we do integrate with state health department. We have the Centers for Disease Control because they have the quarantine station at the Honolulu airport. We integrate with them. World Health Organization, they have some outreach programs throughout the Pacific Islands. And so we're nested with them. And then it's a very joint community. And when I say that is we work very closely with the Navy,
Mm.
the Air Force, the Army, the Marines, even Coast Guard. And so within that, we have a lot of military in a small area and we do connect well. But the thing is now you jump beyond the Pacific and say you want to look in, Europe, or you want to look in mainland United States or the southern region, northern region. Those aren't connecting all. And it kind of goes back to my root of my message is it's a global issue. It's not
Yeah.
regional. Now,
Mm.
yes, historically, most of our pandemics spawn from Southeast Asia, but it doesn't mean they stopped right there. And it doesn't mean they can't go to Europe. It doesn't mean, and we saw, I think, a good example and very recent that a lot of us already forgot is, coming out of COVID-19, right?
Yeah, that's right.
Luckily, the pathogen turned to be less virulent. It wasn't killing people. It wasn't putting them in a hospital. Now, luckily, and we, pray it continues this way, it's a nasty cold to get now. And
Mm.
unless you're in that very vulnerable area, very young or very old or some kind of immunocompromised, not a big threat anymore. But when it came out, it was huge and it was global. And like you said, the exponential growth, right? It was, remember when we were doing the case count on that when it come out, like you'd see, oh, say if you're looking at a state, New Mexico, we report 300 cases. Now you look at it the next day, it's like 700 and they
Yeah,
just exponentially growth because
it's like
it was
1,400.
highly pathogenic. And so it's just spreading all over. And so those are the things that, we look at and that's why it has to be interconnected. I think we're doing a lot of efforts to get it that way. So anyways, like I was saying, as we move away from real world issues within public health, quickly the funding line dries up. So as we're, out of the woods now on COVID, it still circulates, right? But it's not at that threat zone that it used to be. Also, the funding that goes to public health, it kind of is forgotten. What's hard with public health too is if you do it right, it's prevention. You try to stop it before it becomes clinical. But I
Yeah.
think most of the time in history where we get our biggest accolades is reactive public health. That's not what we're supposed to be doing. Like we don't want to put out the fire when it started. We want to extinguish it before it even becomes that, the ember state, not before fire.
So that reminds me of just what is something maybe on a historic, because yeah, COVID was something that definitely we all lived through, and it exposed a lot of our positives and negatives, which we could talk about. But for your personal standpoint as an academic who's done and worked in this field for many years now, like on a historical basis, is there any type of historical pandemic or epidemic that kind of stands out for you, in terms of what it was and the response that we did, and the lessons that we learned from that one?
Yeah. I mean, I think it kind of goes back to vaccine history a little bit on that one
Okay.
because vaccines, and if you talk to historians or public health professionals,
Mm.
are one of the biggest breakthroughs we've had in public health. And if you look too of like our first successful vaccine was, I think it was 1796, and that
Yeah.
was with our smallpox. And, they took the cowpox material of it from, some of the scarring of the boo-boo that was like in the area and then they inoculated an 8-year-old, to see if it had immune protection against smallpox. Smallpox has a high case fatality rate, and that could have wiped out a good, huge portion of the population. And it was a global threat. And we were able to eradicate something like that. That's
Wow.
remarkable, to go something like that. So if you just look at that, just the start of that one, I think it was like move up to like 1800s, 1885, post exposure for rabies vaccination. Huge. I mean, one of the saddest things, and so you see the reality of some of these diseases. I would say, look at this. I mean, if you look at a YouTube clip and you put a human exposure to rabies, see what that does
Mm.
to a person and watch them. They actually have people in their last couple
Wow.
breaths of their life on it. It is a horrific, horrific way to go. And then we now can protect against that. What a breakthrough. And the only reason I'd say like that shock and awe video watch, because then you're like, that is a powerful thing now we can protect against. Yellow fever. I mean, again, United States, no one really knows, right? They don't see it, but you go to places where it's endemic, huge thing that's killing a lot of people.
Mm.
1937, I think is when we, had that vaccination available. Um, and then, it kind of goes even pertussis, something as simple too, like not
Yeah.
so worrisome for adults, but for children, a huge thing.
Mm.
And that was a sad story in the military too, with I know there's vaccines that are so critical and there's ones that, hey, these are nice to have. I wish public health and clinical would do a better job of saying, these are the ones that I would highly recommend. These are the ones that are nice to have. I think we just did this whole blanket statement and, just shot kids up with everything. And
Sure.
I think that's why these anti-vaxxer, things started, because I think we're maybe over vaccinating, but there's some pathogens out there we never want to see again. And so like pertussis, a sad story. And, when I came in the military, I was working in epidemiology, disease surveillance. And
Uh,
so anything that comes into the clinics, we do these large data pulls, and there's reportable infectious diseases that the military needs to know. And so does the CDC. And as we're going through these ones, we had to do a desktop of I think it was a 12-month, 13-month, very young child that died from pertussis. And then we were called to look at the backstories like, hey, was this a vaccine failure? And
uh,
to look in there and the notes within it, the parents said they didn't want to do vaccination for it. And I don't
that's
know
so
if that
sad.
ever went to the parent on that one of the cause of death was something we could have prevented. And that's the last thing you ever want. But some circle was telling them, don't do vaccinations. But that would be one, a must have
Uh,
as, an infant. There's other ones that you might be able to talk through. And that was like one of those ones. Like, yes, there's critical ones and there's ones, or there's also ones too. If you're going to do global travel that, yes, highly recommend these. Yes. Are they endemic United States? No, but where you're going to go, they are. And some are
uh,
seasonality based too. Like incidence and prevalence will change based on the season and stuff too. So all those things, if you actually go to a travel medicine doctor before you're going to go do travel, or in the military, we prepare troops to go anywhere in the world, and we will do consultation on what vaccinations they must have to protect them going into place. So those are things too. So I'd say like, as you just look at public health in general, look at the vaccine history. I think that's one of our
mm.
biggest things we bring to the table is vaccines.
It might possibly be. I've heard some scientists say that might be the biggest thing that we've created, as a scientific community and as humanity has created vaccines because think of all the lives that you probably saved. And
Yeah.
I think, just to go off of what you said is that maybe people just haven't seen that type of
And
like
that's it.
misery.
That's it. And that's why I'm not big on the shock and awe to learn something from, but if you see what so example, like the World Health Organization, 1967, they announced the smallpox eradication. That is a huge thing. And if you look at that, so it had a case fatality rate of 30%. So roughly 3 people in 10 died. Like that's it.
Uh,
And then if you go to the hemorrhagic strand of it, 100% of them died if you got the hemorrhagic version. Just think what that could have done to our population. And just think the 10 people that knowing 3 of those going to die, or let
and
alone
it,
if
it,
they get that really bad strand, then 100% case fatality. And
uh,
so to now, and we haven't seen that, it's in just a few labs in the world that it's being studied, but we've never seen something on that level. Even the death toll with COVID, which is still fresh in our mind, nothing like that, that's that fatal. So I think that's it. We haven't seen it in a long time. People get in circles. They do their own research on it. And that can be
I love that
dangerous,
term.
right?
I did
Dr.
my own
Google,
research.
right? There's great stuff out there, but if you're not cross-referencing, you're not going to primary sources, you're not seeing where that literature is coming from, looking at, the shortfalls of those literature or the limitations of literature, and you're just now taking their word. Or I love the ones on the news, right? Harvard University announces the biggest thing, one study showing something is zero effect. You have to
Yeah.
replicate that study over and over and build a consensus in the literature. And every study has limitations. If you read a study and there's no limitations on there, you got to back away from that very quickly because everything has it. And biggest limitations are usually time and money because at a certain point they have to end the research study and money lines dry up. And that's where other studies could jump on, replicate it, and expand the
Uh-huh.
literature. And that's how you start building a consensus in the literature. And so that's the poison, right? Is now the blessing and curse with the internet. We can do our personal research, but there is so much garbage on there and there's so much great stuff too. And that's why you have to rely, professionals will help weed that out. Okay. This is the literature I'd be going by. This is what's recommended. And sometimes too, it might be exploratory. We don't know yet. And a good research foundation will let you know that. It's like, okay, we're treading into uncharted waters now. Or they'll say the literature heavily supports this. And so those are, oh wait, evidence-based medicine comes from is when we have a strong association or causation and general
Uh-huh.
consensus in the literature. Now we practice it in medicine. And then if they do want to go the exploratory route, they will clearly tell you that because now they're going into an area that it's not 100% where they know what's going on and higher risk at that time too.
What it sounds to me like, maybe what we need to do as better as a nation, because this brings me into, was going to bring me into, but you answered the question already, which is like, how can we talk to the public about public health, and how do we prevent, these type of misconceptions to happen? It sounds to me like these people just need to be taught the scientific method. They need to be taught critical thinking skills. Need to be taught what evidence is and evidence based means, so they can go in and think for themselves. And so otherwise, like, there's a lot of misconceptions. I always like hearing about when someone says, "Oh, that's just a theory." With they're confusing, like that's like a layperson theory, right, versus like a
Yeah.
scientific theory, and
Yeah.
they're totally different.
Yep. Yeah. There's so much like even how that builds, right? That's a chain of hypotheses, right? That builds a theory, not just like, and those are, a lot more scientific method researched, a lot of multivariables that are going into it to come with those conclusions. And so
It's
I think
evidence
it
based.
kind of goes to like, it would be neat to see public health you shouldn't, I think some universities have started to do bachelor's programs in it. Most of them you will never touch public health or epidemiology, industrial hygiene, even surveillance, biosurveillance, even
Mm.
lab support for surveillance. That's kind of a new thing because we think lab for clinical. There's laboratory just for surveillance purposes, looking for infectious agents, looking for things in the air, water, soil, vectors, insects carrying diseases to see what's out there. You won't touch that until grad school at most programs. And
Right.
so I think that's it is I think education is always the thing to get it, at least in people's minds and to think that, how to look through literature, how to even know what public health does, and what's its main process. If you could get that exposure, even maybe in high school, a small block, and I know it comes down to resources, right? You can't get every subject you want in there, but even if you did, I think even like health education, right? I think that starts in like middle school. They don't talk about public health. Every now and then, you'll get some insert, like a quick message, because we might see an uptick in like STDs or something like that, and they'll do a quick little soundbite. But they don't kind of say, well, it's coming from the science and the foundations of epidemiology and public health. And so if you kind of introduce that, it would, I think, help within the discipline and get it out there. But again, it's resourcing.
Absolutely. Oh, yeah. Knowledge is power.
Yep.
Always, it seems like. So what would you think like now? What is the future of epidemiology? Like, what are there emerging technologies or innovations that you think that will transform public health over the next 10 to 20 years?
Yeah, I think this is a great thing too, universities, and I kind of blame myself a little bit too. It's like, why haven't I tried to push through the door more and try to get into public health programs and at least tell like what military public health does? Because I didn't even know what they did, as going in. But we have been on the cusp of, because when you're out there surveilling, you need lab backup to detect and identify what you're picking up. And the lab capability is so huge. And most state health departments, they're getting there. Military has been there and they've always thought globally because that's where anywhere your troops might be. It's not in one region. It could be anywhere in the world. And so they always had that mentality, which is really neat because that's exactly how infectious disease and if you want to stop it, you got to think globally, but it's the technologies behind it. Even like we said, my last time I was a material developer just for preventive
Mm,
medicine capabilities. And within that, we brought, gas chromatography, mass spec in a backpack size unit that we can bring out.
mm.
we can tell you parts per trillion of contaminants that could be in water that you might drink, what could be in the air that you're breathing that could cause
Wow.
illness or hurt you or harm you. And then we also have basically the Min ion, which is the next gen sequencing capability, the size of a large calculator. And we can
Wow.
sequence any, you got to process it, so it could be an insect, for instance. Say we think there might be malaria in this area. So we will
Wow.
do collections for mosquitoes, mince them and process them and put it on these flow cards. And it's actually going to do a whole gene sequencing. And we can even tell you genus species of the malaria that we're picking up. And so these are capabilities that we can bring far forward wherever we're at. A lot of them you
Wow.
have this delay because now I collect, I have to bring it back to the lab, I have to sample, and then I give you an answer. We can get reads on these in 24 hours, which is a
Wow.
huge, and like something that matters, where exponential growth, time is a huge factor, right? So if I could tell you with certainty of what is harming people out in 24 hours, huge thing. Versus if you go back to the capabilities of most state departments, they have to collect, take it back to the lab, takes about 7 to 10 days, and then they'll tell you that. So you already lost that exponential growth because you just 10 days went by where each day more and more people and it's just more and more are getting infected. And so that's something that I think needs to be at all places, mirror off of, and I know it comes down to resources too. And so it makes it expensive. Another thing too is I think with many things, right? Integration of AI. When we're doing large data sets to look for incidence and prevalence rates of disease and all these systems we can go in, even like syndromic surveillance, we're looking at drugstores where, hey, we just see this uptick of cough medicine being purchased,
Mm,
of
interesting.
acetaminophen, like basically, or Tylenol or NyQuil. These are things that could be indicative of, hey, there's a flu, influenza-like symptom uptick. If you can get into these registers and you're having AI sift through all this data, you can do it in such a quicker time and start doing pickups where, okay, we see an uptick in Honolulu, based on syndromic surveillance. We can't do it fast enough with just manual feeds. And even with our computing capabilities, it's speeding it up. The AI, if used appropriately, I think could really capture a lot more on it and make a faster response to public health.
Wow.
So I think that's it. So AI and advanced developments and field confirmatory capabilities would be huge in our field, where even state level, if they could have that.
Wow. That is absolutely seems absolutely correct and fascinating. And hopefully something it will be pushed forward and more states will have these capabilities. I think if what I've noticed about Americans, if Americans want it, funds will be released. So
Yeah.
I think it's about priority and what we prioritize as a state, as a city, as a nation, and what we want to see results for. Well, Dr. Hendricks, I want to just thank you so much for speaking with me. I think we've been friends for a lot of years, and I don't think we ever spoke in depth about epidemiology before. And I always learn something when I talk to you, and I just appreciate you so much.
Yeah. I
And I
appreciate it.
want to thank
Yeah.
you for being here.
No, you got it. Thanks so much. And likewise, we've had such an upgrowing, with our different paths that we go on too, and the dreams that we had within ours too. And it's just neat to see where we've carved out, our niche within whatever
Sure.
discipline it might be in. And the dream state too, right? I'm sure there's so many more things too that you want to take it to another level, expand upon it. And I think that's the whole thing is I would give to anyone, right? You got to keep dreaming and, don't take it as like, this is the definitive no. Where can you expand upon it? And passion too. I think so many people will just chase, how much it's going to make within that. And that can lead to misery. But if you can chase passion and go into that area and enjoy it, those riches will come along with it as well. But that's what I'd really respect with your journey too on that is you dream it, you'd see it, you go after it. A lot of people won't go after it. And that's the huge thing that, I really picked up from you. So it's been a pleasure. So thanks so much for having me on your channel here.
That's right. Well, thanks, Dr. Hendricks. All right. Thank you everyone for listening, and we'll talk to you again real soon.